Welcome to BrainTalk, a podcast from Project BrainStorm about the bipolar spectrum. Your hosts are Dr. Jim Phelps, a psychiatrist and author of several groundbreaking books about bipolar, and Sara Schley, author of the memoir Brainstorm, From Broken to Blessed on the Bipolar Spectrum, and co-creator of Brainstorm the Film, coming to you in 2025. Here on BrainTalk, we'll interview new experts each week about their research and expertise within bipolar, and listeners will call in to ask questions. Let's work together to save lives, end the stigma, and create healing for everyone on the bipolar spectrum and those who love them.
Hey, Jim. How's it going? Good to see you.
Yes, nice to see you. Thank you. I've been off on vacation. You don't think of retirement as deserving vacation, but I went on one anyway.
How's that work exactly? Like, how do you know if you're retired or on vacation?
It has been a little challenging. It's a fun challenge, of course. I have enough projects going that it really actually did feel like a vacation. And now back up to Oregon and the Pacific Northwest.
What'd you guys do?
We went to the American Southwest, the desert near San Diego.
Okay. Well, I hope it was warm and dry. Anyways, I'm really excited to welcome our guest today, Dr. Clare Dolman from across the pond. I'm here near to Boston. Got to jump over to London. She is a really fascinating, wonderful person who lives with bipolar and also done a lot of amazing things that we'll ask her about regarding postnatal, postpartum, and perimenopausal and the whole perinatal journey, and some really innovative stuff with the UK, with the Parliament, and with legislation and funding. And we got to find out how she did it because we're a long way from there here, right, Jim?
Yep, indeed.
All right, so we will invite on Clare Dolman. Welcome, Dr. Clare Dolman. It's so nice to see you and to have you on Brain Talk. Thanks for joining us this afternoon for you, this morning for us.
Yeah, no, that's great. It's really nice to see you again, Sarah, and nice to meet you, Jim.
And you, Doug.
Wonderful. Well, would you be okay with us calling you Clare?
Sure.
All right. So, Clare, we're just excited to hear your story as another fellow person who lives with bipolar, as well as a doctor and a professional in the field. You've got so much to share. Do you want to start just by telling us a little bit of your personal story?
It was quite a funny story, actually, how I went into hospital, because I have bipolar 1. So my family were trying desperately to sort of get me into hospital because of the way I was behaving and whatnot. I was organizing a party, as you do, and at my ex-boyfriend's house. And my sister, she got hold of a psychiatrist to describe how I was behaving and what was going on. And he said, get her into hospital. She has to go into hospital straight away. So I sort of, come into the kitchen and see these two women sitting there in coats. And they start trying to persuade me that I should go into the hospital. And I realized, because I could see that one of them had those lace-up shoes on, they give away for nurses, that they wear those flat lace-up shoes. I thought, oh, I know what this is.
I'm in trouble.
So I made an excuse that I had to go to the loo, and then I made a dash for it. And I just ran up the road. And luckily, my ex-boyfriend, who did later become my husband, he was a rugby player. He ran after me really fast and rugby tackled me to the ground.
Oh my gosh.
It's
a scene for a movie.
Yeah, it was a bit. He dragged me back to the house. And anyway, so I ended up going into hospital.
So Clare, after the rugby tackle and after the hospitalization, you decided, okay, I'm going to learn about this manic depressive thing they say I have. What did you find in 1980? What was it like trying to learn about it then?
It was quite difficult. And I generally couldn't, obviously I looked up in a few books, but I didn't really have much idea. I just felt that my life was now going to be very, very different. Whereas I'd had great ambitions and thought that I could do all sorts of things, having been, pretty successful at school and that kind of thing. I now thought, no, I have to really limit myself and, just make sure I stay well.
And is that because you learned that was recommended, or someone told you you need to change your lifestyle, you need to limit yourself in this way?
Well, partly because I only really had the advice of the psychiatrist who talked to me in hospital, I was put on lithium, for which I'm eternally grateful because it's been fantastic for me.
Mm.
And it did mean that I was, it did mean that I was well and I could function, but I did have that quite sort of experience of brain dulling, that so many people have.
Mm.
And so I did feel that I was intellectually not as sharp or as capable as I had been.
I was telling Jim before that you're one of the most productive people I've ever met. So I think your executive function and your cognition is back to way above average. Can you share? Because I don't want to leave our listeners with the fear that lithium is going to dull their brains, because it certainly hasn't dulled yours.
Well, to be absolutely honest, I've reduced it a lot. I've reduced my dose a lot, and I started doing that in my late 30s, early 40s. I did ask my psychiatrist, and I came down from 800 that I was on for like years, and I came down very, very gradually over months and months, in fact years, to 550. So I almost halved it, and I haven't really, I still have my tests every 6 months, and I haven't dropped very low in the therapeutic range. So it's been great for me.
So Claire, when you got down to 0.5, did you feel like your cognition was improved?
Yeah, definitely. It was
Yeah.
quite interesting because it also gave me more confidence.
Listening to you might make it sound as though you just have to manage your own lithium. Thank you very much. Make up your own mind. I would hope that most psychiatrists nowadays would be open to having their clients, their patients, say to them, I'd like to change my lithium dose, and have a rational conversation about that. Pros and cons. Let's look at what risks you face and so on. So not changing one's dose on one's own as a general idea.
So we could just go back in time again to now you're in your young 20s, I believe, and you marry the rugby player, you decide to have a child, you get pregnant.
Yeah.
So then what happens?
So I was fine in my pregnancy, but then within days of having my daughter, I started to have an episode. I was quite irritable and elated, but I was also quite, I was very sort of uptight, and I couldn't sleep at all. So I had to go get hold of the private psychiatrist again. And he came to see me at home, and he said, you've got to come in. So I went into the hospital for 5 weeks, I think. And
Wow.
That did the trick.
It's interesting about how differently these details are managed now. So, for example, it would no longer be the routine recommendation to go off lithium during your pregnancy.
Yeah.
It would no longer be the routine recommendation that you would have to stop breastfeeding even if you're taking lithium. That's a very complicated one, but not a routine recommendation necessarily anymore.
Yeah.
And hospitalizations wouldn't last 5 weeks. They would last a few days in most places, at least in the United States.
Mm-hmm. And I'll just say, Jim, you remind me that we had Dr. Crystal Clark on the show recently. The episode you can find up on our website right now. I think you met her, Claire. She's a perinatal psychiatrist from the U.S. And I loved her line. She would say, we asked her, what would you say to a woman with bipolar who wants to have a child? She said, we can do this together. We can do it. Yeah. And I love the we part, like we can do this. We're going to manage it based on your individual situation. And she's done beautiful work that way. So we didn't have that, you and I, in the 80s, but.
No, I think if I had been advised to go straight onto my lithium immediately, after I gave birth, which is what I did the second time, my son, and I was fine. I mean, I still didn't take it during the pregnancy and I was fine. But then immediately afterwards, I went straight onto it.
Proves Jim's theory, I think.
Yeah.
So there's a couple other, ways to go in our conversation, because we want to hear all about, how you decided to pursue this path professionally.
When I lowered my dose and I got more confidence, I went back to uni. I was more interested in finding out more about my condition. As part of my course, I got involved with the charity here, Bipolar UK. Professor Ian Jones, who's a great friend of the charity, immediately asked me, would I do these workshops with him that he'd started doing for women and their partners about, what they should know if they were thinking about having children. They were very well attended, but I was so shocked by some of the stories at them. I was trying to be more upbeat because he was doing all the risk and everything, and the charts and the medical. I said what had happened to me and that, turned out okay in the end. A woman sitting right in front of me said, "Oh, that's what I did. I stopped my lithium. I got pregnant and then I was so ill that I had to have an abortion. And I was in hospital for 7 months with depression."
Wow.
And the woman directly next to her said that the same thing happened to me. I had to have an abortion and I was in hospital for 6 months. And I was like, because I was being all jolly about it. And I thought, oh my God, this is terrible. I said to Ian, we have to do, what's the research on this? And he said, well, there is very little research. So I just switched to doing my PhD about decision making for women with bipolar about pregnancy and childbirth, because I just felt like that's so much more important,
So interesting. Wow. Thank you.
Could you give us the fast forward? Because that remained your focus. And where are we now? What have you managed to bring about with this focus?
It's done fantastically. And we went from when I started my PhD and I was interviewing women about their experiences, only about 45% of women in the UK had access to a mother and baby unit, which is our best level of service. Now it's 100%.
Wow.
100%.
100%.
Can you tell us about the mother baby units? Because when I first learned about this, I was stunned because we don't have anything like this in the States. And you guys have a whole miracle story.
Yeah,
how you made this happen. So
it's amazing. Women who are ill postnatally in the immediate postpartum could be cared for with their baby. Amazing. So the baby goes with them to the unit, and they have nursery nurses so that if the woman is very ill and can't cope with the baby, the nursery nurses look after the baby. But, they really help the woman to deal with the baby. And usually women stay in for about, I think the average is 5 to 6 weeks. It's such a nice environment in the mother and baby unit. They're just wonderful.
We got to visit when we came to film for BrainStorm, the film. I was just blown away. I was like, boy, this would have been heaven. We don't have anything like this, and it's phenomenally. It's so humane and kind, and loving to have this. You and I have shared the story, Claire, where I was completely stable, having finally got my diagnosis after 25 years, perfectly good, brain back, high functioning. And all of a sudden I had this, descent into hell during perimenopause with no explanation, and nobody knew. Like even my expert bipolar psychiatrist didn't know. OB-GYNs didn't know. Primary cares didn't know. Cousins and family. No one was talking about it. No one.
No.
And, now we know, and thanks to you and your research and your efforts, and we'll put show notes. When people look up this episode, they'll see, because you've got lots of webinars on Bipolar UK helping people, and we'll hear more about that. But there was one paper that you shared with me that was along the lines of how many, you did a qualitative, I think 1,000 people or so, what percentage of the women were told that they might have a relapse, and what percentage actually had a relapse at perimenopause. You remember that paper?
Yeah, no, we did a survey with Bipolar UK asking women, and we had over 1,000. I asked them how many of them knew that they might be at risk at that time, and it was fairly pitiful. I think it was 30 to 40%. And to be honest, I think some of them was because they'd seen my webinars about it. And I asked how many of them had been told by a professional that they might be, at risk. And it was like 85% had never been told that there was, a hormonal risk. When I first went into the world of research, I was shocked that comparatively, there's much less research on women anyway, isn't there? Loads and loads of the meds that we take have not been tested on women originally, because in America they were left out of the research, weren't they? Then there's also what we're aware of in the UK is there's a bias against bipolar, because there's been a real emphasis on schizophrenia and depression, and bipolar has kind of like fallen in the middle somewhere, and they haven't really taken much notice of it. So it's sort of in proportion to the harm it causes, there's much less research than on the other conditions. Then if you're a woman with bipolar, then you think, well, where is, now they're talking about menopause generally affecting women and that there should be more knowledge about that. Absolutely. But I keep hearing these things, and they're having documentaries on TV about menopause and whatnot. But I think, well, that's all well and good, and I'm very much in favour of that. We need to know more about that. But nobody's talking about the women who die because of it. We have women who die,
Mm-hmm.
and yet nobody seems to be interested. And I just find that, very annoying and sort of motivating, really.
So we know that no one knows about this perimenopause thing. It can be a disaster. You were smart enough, therefore, to know to intervene in advance. So what did you do? Because it's pretty brilliant.
Yeah, well, I mean, I think I was very lucky because it was when I was in my 40s that I was doing my PhD. So I was, reading everything about bipolar basically online. And so I was thinking, well, what is the research on this? And obviously, there isn't a huge amount of research, but what there is that self-report indicated that a lot of women seem to relapse at that time. So I went proactively to my general practitioner and said, right, I want to go on HRT. And so I started it, just before I was probably going to have symptoms. And I've been on it ever since. I'm just staying on it. And I'm so glad I did because, literally every week I'm contacted by somebody who has had a most terrible experience. The trouble is, it seems like, and this is again a problem with the research, but it seems like if you get that really bad trigger at perimenopause, they then seem to have a very hard to treat type of bipolar, and what worked for them before doesn't work for them anymore.
Oh.
And they're really in trouble because, they're just going back and back into hospital.
Thank God you're doing the research. And just HRT being hormone replacement therapy for folks who might not know that acronym.
Right.
That's a miracle.
Of all the interventions that you have engineered, and it seems as though there are many of them, what are the one or two that you think have been the most effective in terms of bringing about change?
Yeah, us generally here in the UK.
Yes, because
I
want to apply it to us in the United States.
Good luck.
Yeah. Well, I mean, I think the emphasis on improving perinatal services has been really, really important because it not only in itself, because it's helped so many people, but it's also sort of set a standard. It's kind of like shown the way as to what services can be like. We had a great radio program here recently. They interviewed Dr. Trudy Serevanatri, who is very high up in the Royal College of Psychiatrists, but she also runs the Bethlehem MBU. And they interviewed her about the mother and baby unit. And this chap who was interviewing her, he said, I can't believe this service sounds so wonderful, a bit like what you were saying, Sarah, and it just sounds like that's the standard that we want for all our mental health services.
Yes.
And she said, absolutely, that's what we do want. And I kind of feel like it can be a bit of a sort of, standard bearer for this is a really good service. This is what we should be aiming at across the whole of mental health.
Yeah. And to go from 30 or so percent of units having such arrangements to 100% is an astonishing achievement.
Well, there's a story. We have to have Dr. Dolman back for this story, which I know, which we won't be able to get to. We don't have enough time, but they commissioned the London School of Economics to do a study, find out it was costing X billions of euros, you're going to tell me, went to Parliament with the study. Am I right, Claire?
Yeah. No, it's done fantastically well. And now, because one of the other things that I'm very involved with now is trying to spread this message globally. So we use, that economic report, and we're trying to encourage other countries to have their own alliances and tell them, try to help them with sort of tools and things as to, how to go about that. And it's been going great at the moment. Friday we had Norway have brought 2 health ministers over and 40 delegates to learn what the perinatal
Wow.
service is like here
Wow.
in the UK.
Wow.
We were blown away.
Amazing.
We couldn't believe it, it's fantastic. We always say we need, the clinical expertise telling you this is what is really needed and this is why, medically, clinically, plus the lived experience story. And then that gets the emotional impact. This is why it's really important, why we need these services. But then you also have to have like the economic reasons, because this is going to save you money, because an awful lot of politicians are only going to do it if it's
Right.
economically viable.
And it was, the investment is, small fraction of what LSE came up with as the economic cost of,
Yeah.
what women, probably a whole bunch of metrics, missing
Yeah.
work, being away from their kids, the impact on the kids. So that's brilliant. I hope we could do something similar. And, what I've said before is, well, women are, last count, we're about 50% of the global population. And about 100% of us will go through menopause if we get that far. That's a lot of people, right?
That's
So I'm
people.
really grateful for your research and your work, and your whole story is magnificent. And there's so much more that we want to ask you, but we're going to have you back for another follow-up if you will join us again.
Absolutely. I'd love to. No, it'd be great.
So the big picture is what a spectacular job you've done, and how grateful people in the bipolar community and those of us who treat that community, how grateful we should be for what you've done.
This is a standing ovation.
No. I'm very grateful that I found it as a cause, because we all need purpose in life, and that's another thing that keeps you well. And I feel that I have my purpose in life, and so it's been very good for me as well.
Well, it's wonderful to have you. Stay well, and hopefully we'll talk again soon and see you
absolutely
before too long.
Okay.
Thank you.
Okay.
Bye.
All right, Jim. What'd you think?
This is when we say "wow," right?
This is the wow period. Yeah, the wow section of the
Amazing.
podcast.
Just the breadth of what she's done is phenomenal. Going from kind of mental health to public health, and thinking about menopause as a public health issue, at least among people with mood disorders.
Yeah, it's really incredible. Can you describe the distinction, mental health to public health? So that's the individual level versus the
Yeah,
national
so
level.
as a clinician, you think about the patient in front of you,
Mhm.
or as a professional, you think about the entire population and who's at risk
Mhm.
and what interventions. There's a different set of interventions for an individual than for the general population.
Got it. And she's doing both. Yeah.
Yes.
What they're doing over there, we had the privilege of going over and for BrainStorm, and it's really something, as you could tell. And there's so much more to learn from Clare. I'm thrilled personally that somebody's doing this research on menopause.
I do find myself going, okay, well, wait a minute. How much do we know? What percentage of women are having enough trouble? Are we really going to start recommending hormone replacement therapy for every woman with bipolar, like basically prevent menopause? Or are there a subset of women who are at greater risk, and how are we going to identify them? And we need answers to those questions before we start thinking about, at the public health level, what are the recommendations?
Yeah, right. This is the issue. No one's done research because they think we're old ladies and they're going to push us out to sea. But we're right smack in the middle of our lives. And yeah, she didn't mention that paper that I read that she did, or the results of the survey was that while 89% were never told anything from their practitioners, close to 60% did have a relapse.
Yes, and I would be one of the practitioners who didn't say anything. It was not on my radar to say, but when you are approaching, and because the age of menopause is so variable, there is a period where you may be at risk again, and we need to be working proactively in the same way that we did thinking about pregnancies for that period of time. That just was not there.
And that's a stunning admission, Jim, and thank you for your honesty, but coming from you, because I consider you the gold standard of the psychiatrist who understands bipolarity, for not even you to know, which was my experience, my doctor didn't know. That's really a stunning omission, isn't it?
Embarrassing to admit it in this context after.
But thank you for it. It just goes to show how little research and little education there is in the field. So we're hoping to change that.
Yes.
And thanks to people like Clare. Wow.
Yeah.
She's got some great resources that will be in the show notes. A brilliant webinar about perimenopause and the Bipolar UK link, and just lots of other resources. A previous episode with Dr. Sherry Johnson, we talked about creativity and bipolarity.
Yeah.
Once we get better, look out. When people like us are healthy, wow. And that's Clare, right? She's above average.
Exactly. And she's like, people worry about, the dulling effect of lithium. If this is dulling, then.
But I think that's what she was saying. Once she did ratchet down to 550, she got her brain back. And you can see she is very sharp.
Yes. Carefully managed. Look, this is possible.
Really possible. So that's great. Very uplifting. Love it. Anything else you want to share? Lots.
Is everybody going to be like this? It seems like every single.
Now you like this job, right?
Yeah, it's very good.
Job. I feel very privileged to get to, chat with you with somebody like Dr. Clare Dolman. So over and out till next time.
Thanks so much for joining us on BrainTalk, our bipolar spectrum podcast. BrainTalk is a program of BrainStorm, a multi-platform project about the bipolar spectrum, which includes Sara Schley's memoir and a full-length documentary coming in 2025. We aim to save lives, crush stigma, and maximize healing for all people living with bipolar and those who love them. For more information, head to www.brainstormthefilm.com. To call in to a future episode and ask questions, go to brainstormthefilm.com/podcasts.